Hi YouTube family, welcome to Concept in Medicine. In today's tutorials, we are going to be looking at the oral hypoglycemic agents. Interesting, right? Kindly make sure to subscribe to my channel, comment, share and like as well. Now let's begin with the oral hypoglycemic agents. First of all, we are going to be looking at the E classes of the oral hypoglycemic agents. Let's start with the first one, that is the biguanides. So for the biguanides, an example of a biguanide is metformin, which is very popular and common. It is the only approved biguanide currently in the market. Now let's look at the mechanism of action of the biguanides, that is metformin. So the first mechanism of action is that metformin decreases hepatic output of glucose, and that constitutes the main mechanism of action. Secondly, it increases the sensitivity of the hepatic cells as well as the peripheral tissues, that is the muscles and the fat, to insulin, enhancing glucose uptake by these cells. And that will constitute the minor mechanism of action. The main effect of metformin will be that it decreases the hepatic output of glucose. Now let's move ahead and look at the side effects of the biguanide, that is metformin. So for the side effect, we can think of the first one, which is the metallic taste. For the metallic taste, it comes with high doses of the metformin. If a patient is taking a high dose of metformin, let's say 1 gram twice daily, then they are likely to have such a side effect. Another side effect is nausea. Another one we can think of is abdominal pain, diarrhea, lactic acidosis. And for lactic acidosis, it's conditional, meaning that with that, the estimated glomerular filtration rate has to be analyzed. Meaning for patients to be on metformin, you would want to request for a renal function test to know the estimated glomerular filtration rate. And for metformin usage, if the estimated glomerular filtration rate is less than or equal to 36 milliliters per minute per 1.73 meters square, then metformin should not be given to such a patient, because if given, it will precipitate a lactic acidosis. Then finally, another side effect is weight loss. That is why in conditions like polycystic ovarian syndrome, yes, metformin can be given to enhance weight loss, because such patients tend to gain a lot of weight. All right, now let's move on to the second class of the oral hypoglycemic agents. And that class, we call them the sulfonylureas. Let's have a look at the examples of medications that fall under that class. So formerly, there used to be the first generation sulfonylureas. Currently, they are no longer in use because of the high incidence of side effects in them. High incidence of side effects in patients on the first generation sulfonylureas. What are the examples of the first generation sulfonylureas? For that, we can think of the chlorpropamide, we can think of the acetohexamide, we can also think of tolbutamide, and finally, we can think of what? Tolazamide. But currently, the first generation sulfonylureas are no longer in use. Then let's have a look at the second generation, which are in use. For them, they will be ending with IDE. So we can think of the first one, glipizide, glicazide, glimepiride, and we can also think of glibenclamide, which is also known as glyburide. Now let's have a look at the mechanism of action of the sulfonylureas. So first of all, you should know that they stimulate the beta release of insulin. And the question is, how do they do that? So first of all, you should know that their receptors are components of the adenosine triphosphate, that's ATP, dependent potassium channels in the beta cells of the pancreas. So when the sulfonylureas bind to the receptors, they tend to inhibit these receptors, and by so doing, decreasing the resting membrane potential. And as that happens, it enhances the influx of calcium ions into the beta cells of the pancreas, stimulating the beta cell insulin release. So in short, they stimulate the release of insulin by the beta cells of the islets or Langerhans of the pancreas. I believe we are making sense out of that. Now let's look at the side effects of the sulfonylureas. The first one is that there is weight gain in patients who are on sulfonylureas, and also likely hypoglycemia. Now let's move ahead and look at the third class, and that will be the sulfonylurea receptor binders, also known as the meglitinides. Examples, we have the nateglinide and the repaglinide. The mechanism of action. You should know that the sulfonylurea receptor binders, the mechanism of action is similar to that of the sulfonylureas. That is, they enhance or they stimulate beta cell insulin release. But the only difference is that for the sulfonylurea receptor binders, they have a different binding site. It means they bind at a different site before inhibiting the receptors to kind of have an effect on the ATP dependent potassium channels in the beta cell. Now, the side effects is going to be same as well. That of the sulfonylureas. That will be the weight gain and hypoglycemia. Now let's move ahead and look at the fourth class. That will be the thiazolidinediones. The thiazolidinediones, also known simply as the glitazones. The thiazolidinediones can be simplified as what? TZD, and also known as the glitazones. Examples, we can think of the pioglitazones, we can think of the rosiglitazone and the troglitazone. Mechanism of action. You should know that the glitazones or the thiazolidinediones, the main effect is increasing the sensitivity of hepatic cells and the peripheral tissues such as fat and muscle to insulin, and by so doing enhancing glucose uptake by these cells. That is the main effect of the thiazolidinediones or the glitazones. When we were talking about metformin, we said the main effect of metformin is decreasing hepatic glucose output. But when we come to the glitazones or the thiazolidinediones, for them, their main effect will be to increase the sensitivity of these cells to insulin, enhancing glucose uptake by these cells. How do they do that? How do they do that? So the glitazones or the thiazolidinediones, they activate one or several peroxisome proliferator activated receptors. It could be alpha or gamma. And when they do that, these activated receptors enhances ligand binding. And once ligand binding is enhanced, it's what? Increases insulin signaling. And by so doing, increasing the sensitivity of insulin to hepatic cells as well as peripheral tissues. That's the muscles and the fat, enhancing glucose uptake by these cells. Another mechanism of action of the thiazolidinediones or the glitazone, that is a minor effect, is that they also decrease hepatic glucose output. Now, let's move ahead and look at the side effects. So for the side effects, we can think of fluid retention, fractures, which are going to be pathological fractures, secondary to what? Osteoporosis. We can also think of hypoglycemia, and finally liver dysfunction. And for the last one, that's the liver dysfunction, that explains why a patient on the glitazones or the thiazolidinediones is supposed to do a liver function test every 8 weeks up to a year to ensure that that side effect is not realized, and if realized, corrected. And the final thing about the glitazone is that if you look at the medications that we mentioned, not all of them have the same effect. That is with regards to the alpha or the gamma PPAR, that's the peroxisome proliferator activated receptors. If you look at the rosiglitazones and the troglitazones, they are purely alpha. They exert the alpha effect. But if you take the pioglitazones, they exert both alpha and gamma effect with respect to the peroxisome proliferator activated receptors. I hope we've made sense out of that. Now let's move ahead and talk about the next class of medications. So the next class of medication, we are looking at the alpha glucosidase inhibitors. For the alpha glucosidase inhibitors, the examples we can think of acarbose, miglitol. Now let's move ahead and look at the mechanism of action of the alpha glucosidase inhibitors. From the name we said alpha glucosidase inhibitors. So let's talk about the alpha glucosidase. The alpha glucosidase is an enzyme secreted by the brash border cells of the intestines. And what do? They degrade complex carbohydrates such as sucrose, maltose, dextrins into glucose. And the resultant effect will be an increase in the level of serum glucose when they do that. And we are looking at hypoglycemic agents. What do? They reduce the level of glucose. So in that case, the alpha glucosidase inhibitors, they will block the action or activity of alpha glucosidase, thereby reducing serum glucose levels. I believe we are catching the concept. Now, let's move ahead and look at the side effects of the alpha glucosidase inhibitors. For the alpha glucosidase inhibitors, the side effect we can think of flatulence, diarrhea, abdominal discomfort or pain, then finally bloating. Let's have a look at the next class of oral hypoglycemic agents. And the next class will be what we call the incretin mimetics or the glucagon-like peptide 1 agonists. Let's have a look at the examples. So for the examples, we can think of exenatide, liraglutide, dulaglutide as examples. Now let's have a look at their mechanism of action. So for the mechanism of action, we have to look at the function of incretin. Then the question goes, what are incretins? So you should know that incretins, they are enteroendocrine hormones produced by the K and L cells, which are dispersed all over the gastrointestinal tract. And what do? First, they delay gastric emptying and also inhibit postprandial glucagon release. What else do? They also stimulate glucose-dependent beta cell release, meaning that any food that enters into the GIT gets broken down into glucose, or the moment glucose is produced, there is signaling to the beta cells of the islet of Langerhans to release insulin. And that's what the incretin mimetic do, just like the glucagon-like peptides. The side effect we can think of nausea, vomiting, and also weight loss. Alright, now let's move ahead and look at the 7th class, that's the dipeptidyl peptidase inhibitors, DPP4 inhibitors, also known as the gliptins. Let's look at the examples. So for the examples, we can think of sitagliptin, sasagliptin, and vildagliptin. Let's look at the mechanism of action. So you should know that the DPP4, that's the dipeptidyl peptidase 4, is an enzyme that rapidly degrades and inactivates glucagon-like peptide 1 via cleavage of the N-terminal 2 amino acid. So inhibiting this enzyme would mean an increase in the level of circulating glucagon-like peptides. And by so doing, what are we going to have? We are going to have an increase in the beta cell insulin release, and that would decrease the level of glucose in circulation. Now let's have a look at the side effects of the DPP4 inhibitors, that's the gliptins. The side effect we can think of nausea, vomiting, and finally weight loss. So in certain scenario where you are thinking of using sulfonylureas, or there's that incumbent factor of obesity, it is better the sulfonylureas are replaced by the glutens, that's the dipeptidyl peptidase 4 inhibitors. Now finally, let's look at the 8th class of the oral hypoglycemic agents. We call them the selective sodium glucose co-transporter inhibitors. Selective sodium glucose co-transporter inhibitors. Now, what are the examples of these medication? So the example we can think of empagliflozin. We can also think of dapagliflozin, which is available on the market as Forxiga. Mechanism of action. They block the selective reabsorption of glucose at the proximal convoluted tubule of the nephron, leading to glycosuria, and that will decrease the level of glucose remaining in circulation. It is a new drug that has been introduced not long ago. The side effect, we can think of diarrhea, UTIs, and finally vaginal candidiasis. And that brings us to the 8th oral hypoglycemic agent. Finally, we are going to reclassify the oral hypoglycemic agent into classes with regards to their effect on insulin. That is going to be the insulin sensitizers and the insulin secretagogues. The insulin sensitizers, they will be increasing the sensitivity of the cells to insulin. Then the insulin secretagogues, they will stimulate the beta cell insulin release. So for the insulin sensitizers, the biguanides are considered one of them, and also the thiazolidinediones, or what we call the glitazones. They are also known as what? The insulin sensitizers. Then for the insulin secretagogues, we are thinking of the sulfonylureas. We are also thinking of the sulfonylurea receptor binders, that's the meglitinides. And to a lesser extent, we can think of the glucagon-like peptide 1 agonist, as well as the dipeptidyl peptidase 4 inhibitors. I believe we've made a lot of good understanding in this session. Kindly make sure to subscribe, like, share, and also make sure to leave your notification bell on. And don't forget to comment the next concept you would like to see on my channel. Don't forget to comment the concept you would like to see in my next tutorial video. My name is Dr. Del, and this is Concept in Medicine. Bye-bye.